We all have that image, don't we? A really sick patient going into a hyperbaric chamber. It feels very high tech, maybe a last resort.
Hmm.
But what if that person isn't just sick, but critically ill, like needing full ICU level support? How do you even manage that inside one of those chambers?
Yeah, it's a fascinating question. Uh, Hyperbaric oxygen itself is pretty specialized,
Right.
But then you add the complexity of critical care, ventilators, monitors, organ failure.
Yeah.
The level of planning just skyrockets.
Okay, so let's get into this. For this deep dive, you've shared some really detailed chapters from hyperbaric medicine practice, and this isn't like the 101 stuff, is it?
No, not at all. This is deep in the weeds, expert level.
Yeah.
It's all about the practical side of treating critically ill folks in those single-person monoplace chambers.
Monoplace, right, single person.
Exactly. And these chapters, they really lay out the nuts and bolts, how teams can actually do this safely. All the adaptations needed, the expertise. It's quite something.
So our mission today, then, is to pull out the key takeaways from these experts. We want to understand what it really takes to bring ICU care into that unique hyperbaric environment. Sort of a behind-the-scenes look. Ready to jump in?
Absolutely. What I find really compelling is the sheer ingenuity involved, the problem solving that's made this possible for really sick patients.
Okay, let's start with the big hurdle. I mean, initially, doctors were pretty cautious about putting unstable patients in these monoplace chambers. What were the main worries?
Well, yeah, understandable caution. A big one was the lack of immediate hands-on access. You can't just reach in easily.
Right.
Plus, there were questions about fitting all the necessary ICU gear inside, making sure it worked under pressure, and the pressure limits themselves usually around 3 atmospheres absolute, or 3 ATA.
3 ATA. Okay, that's like being, what, 66 feet underwater, roughly?
Exactly. So less access, maybe limited equipment.
Yeah.
That makes you nervous when your patient is really unstable.
Makes sense.
But, experience has shown, and these chapters back this up with studies, that it can be done safely. The key phrase, though, is with highly trained staff and the right equipment.
Right. That's crucial.
It's definitely not something you do lightly.
Which brings us to this really interesting point you mentioned, maybe even counterintuitive. Treating these patients in a monoplace chamber can sometimes be easier and safer than just transporting them, especially by air. How does that work?
Well, think about moving a critically ill patient. Air ambulance, ground transport.
Oh.
You've got noise, vibrations, tight spaces, maybe unpredictable conditions.
Yeah, true.
Inside the chamber, okay, it has its own challenges, but once they're in, it's a very controlled environment. Temperature, pressure, oxygen delivery, it's all precise. So in a way, that stability can be less risky than the chaos of transport for a very fragile patient.
That's a fascinating perspective. It really sounds like the hyperbaric unit has to operate almost like a satellite ICU, not just down the hall somewhere.
Absolutely. Proximity helps. Having the right gear is essential. But the big thing, people, staff who get both critical care and hyperbaric medicine.
Yeah.
The physiology, the pressure effects. The text even mentions a case where they literally move the chamber into the ICU.
Yeah.
That tells you how integrated it needs to be.
Wow, moving the whole chamber. That really drives it home. It's not just sticking someone in a tube, it's a whole strategy.
Right.
And it needs that multidisciplinary team you mentioned. Who's involved?
It's definitely a team effort. Physicians, advanced practice clinicians like MPs and PAs, nurses, respiratory therapists, the common thread, they all need that dual knowledge base. Critical care and hyperbaric medicine and physiology.
So deciding to even do this for a critically ill patient isn't automatic. There's a serious risk-benefit calculation first, right? It's not just, oh, gas gangrene, off to HBO2.
Not at all, no. The text uses a tough example. Someone with bad respiratory distress, chest tubes, needs lots of ventilator support, and they get gas gangrene. Yeah, HBO2 is good for gas gangrene, but the risks of moving and treating someone that unstable in the chamber, they might actually outweigh the benefits. It takes a really experienced team to make that call.
Okay, so the team decides the benefits win out. What happens before the patient even leaves the ICU? Sounds like a ton of prep.
Oh, it's incredibly detailed, meticulous. First, obviously, informed consent. That's number one.
Of course.
Then you need baseline ventilator settings, latest blood gases, all documented. If they have an endotracheal tube, the little balloon that seals the airway, you have to take the air out and refill it with sterile saline.
Why saline?
Because air expands under pressure, right? Saline doesn't. So you avoid potential damage to the trachea. It seems small, but it's critical.
Got it.
Then cap off any lines you don't absolutely need. Chest tubes, they need special one-way Heimlich valves because the regular drainage systems can break under pressure. Switch ICU monitors to portable ones. Optimize sedation. It's a whole checklist.
That is a lot. And then there's this final check the safety timeout right before they go in. What's that cover?
Absolutely non-negotiable, that timeout. It's the last chance to catch any prohibited items. Fire hazards are a huge concern in that oxygen environment.
Right.
But it's also checking all the IV connections again, confirming the right drugs are running at the right rates, ventilator tubing is secure, no personal items snuck in, and making sure the patient can equalize their ears if possible.
And you mentioned the FDA has concerns about line misconnections. With all those tubes on a critical patient, I can see how that could happen.
It's a real risk. Disconnecting, reconnecting, it increases the chance of error. And a misconnection can be disastrous, even fatal. So that timeout is just vital.
Okay, patient prep, team ready. What about the hyperbaric unit itself? It needs more than just the chamber, right? What emergency gear has to be on hand?
Yeah, it basically needs to be a mini ER right there. Full airway cart, laryngoscopes, tubes, everything for intubation. Working ventilators, obviously. Hemodynamic monitors, heart rate, BP, O2 sats.
Defibrillator.
Definitely. Defibrillator with pacing, good suction. Pulse oximeters, OV supplies, galore fluids, catheters, tubing, chest tube trays, and a full stock of critical care drugs. Everything needs to be right there.
And space. Seems like you'd need room to maneuver around the chamber.
Exactly. You need clear access from both sides, especially for getting the patient in and out. And if any urgent interventions are needed, you can't be crammed in.
Now, the chamber itself, you mentioned adapting standard ICU gear. What kinds of modifications are needed for these monoplace units?
Several key things. You need electrical pass-throughs to connect monitors outside to the patient inside. Same for 4V lines. Fluid and drug pass-throughs are essential for continuous infusions, and a gas pass-through for the ventilator hose. Beyond that, there are more specialized things like systems for suctioning drains inside the chamber, ways to give short air breaks during ventilation, non-invasive BP monitors that work under pressure.
Air break.
Yeah, short periods breathing air instead of 100% oxygen to reduce toxicity risk. Also specialized pulmonary artery monitoring setups, and even these multi-lumen things that let you run like 4 IV lines through one port.
Wow, multi-lumen penetrators. That shows how complex the IV needs can be.
It really does. These adaptations are crucial, but they also show, the unique demands here. Maybe areas for more innovation down the line.
Absolutely. Okay, let's touch on defibrillation. Seems risky in a high oxygen environment. What's the thinking there?
It's a valid worry. Spark plus high oxygen equals potential fire. So some people recommend moving the patient away from the chamber right after they come out before shocking them.
Makes sense.
Although the author mentions personally doing it successfully right beside the open chamber a couple of times without issue.
And there was that editor's note saying the extra oxygen disperses pretty quickly once the chamber's open.
Yeah, that note suggests the immediate area doesn't stay hyperoxygenated for long. But the bottom line is you must have the defibrillator, cardiac monitor, bag valve mask, and intubation gear instantly ready. No question.
Okay. Patient needs to move from the ICU to the hyperbaric unit. Talk about that transport. It's not just wheeling them down the corridor, is it?
Definitely not. You have to maintain full ICU-level care during that move. Having that experienced critical care team with the patient is non-negotiable.
Right.
If they're on a ventilator with PEEP, that pressure that keeps the air sacs open, you absolutely have to maintain that PEEP during transport. Use a portable ventilator or a bag valve with a PEEP attachment. Losing PEEP can really hurt their oxygenation.
Okay.
You might even need to check blood gases during transport if you're worried. Continuous monitoring ECG, blood pressure, especially if they're on pressors, drugs to keep BP up, often TCO2 and pulse oximetry too. And critical IV drips, like those pressors or TPN, usually need to keep running on portable pumps.
It really is a mobile ICU setup. And the need for emergency drugs on that transport cart?
Absolutely critical. You need things like epinephrine, lidocaine, ready to go with all the supplies to give them fast, a well-organized cart holding the pumps, monitors, oxygen suction, emergency meds. It's essential for a safe transfer.
Okay, they've arrived at the hyperbaric unit. What's the process right before they go into the monoplace chamber?
So all that monitoring continues right up to the point of entry. Continuous BP if they have an arterial line. Then you carefully connect the endotracheal tube to the hyperbaric ventilator circuit. Adjust the settings based on how they were before and during transport.
And the ventilator itself, the Seachrist 500A, is common, right? How does that work with oxygen?
Yeah, the 500A is pretty standard. It actually pulls in the gas around it to give the breath.
Yeah.
So if the chamber is filled with 100% oxygen, that's what it uses. But if the patient needs a really high FiO2, you might need to bleed supplemental oxygen in right at the ventilator's intake valve inside the chamber.
Okay. And pulse oximetry is key throughout.
Constant pulse oximetry, yes, absolutely essential.
What about clothing? You mentioned fire risk. Very specific rules there.
Extremely specific. NFPA guidelines are strict. Generally, it has to be 100% cotton or a specific cotton-poly blend tested for fire safety. No synthetics, no wool, no silk.
And if the patient is comatose or agitated, how do you keep them safe and prevent lines from being pulled?
Good question. For comatose or heavily sedated patients, soft restraints are often used carefully just to keep limbs secure and prevent them pulling at tubes.
Mm.
If someone's combative or very anxious, sedation is usually needed, sometimes even paralysis if they're intubated. But the staff doing that needs specific anesthesia or critical care credentials. It's serious medication.
Right.
Existing drains might be capped, or special systems allow suction inside. Chest tubes, as we said, need those Heimlich valves.
And those IV pass-throughs again if you have lots of infusions.
Yeah, it's a major logistical puzzle, especially with older chambers with fewer ports.
Yeah.
Try to combine compatible drugs carefully into one line if possible.
But you have to be careful not to accidentally bolus a potent drug.
Exactly. Never push other drugs through a line running something critical like a pressor. You need deep knowledge of drug compatibility. Sometimes these special multi-lumen pass-throughs are the only way if you just have too many lines. Newer chambers are better designed for this now.
What about the endotracheal tube itself? Any specific adjustments for the hyperbaric environment?
Generally, you want a low-pressure, high-volume cuff, and that cuff management is key. Air out, inflate gently with sterile saline just to seal before pressurization. Then after the treatment, saline out, re-inflate with air, check the pressure, and secure taping is vital. Soft restraints can add another layer of safety against accidental extubation.
And there was some debate about prophylactic myorotomies making little holes in the eardrums.
Yeah.
For intubated patients who can't clear their ears.
Yeah, that's been discussed. The idea was to prevent ear barotrauma since they can't tell you their ears hurt.
Right.
But many practitioners, including the author here, don't do it routinely. They find that adequate sedation often lets the middle ear passively equalize pressure anyway. There isn't strong evidence saying you have to do it for everyone.
Okay, patients in the chamber, pressure's up, access is limited. How do you monitor them effectively now?
Well, you can still see them obviously through the acrylic shell. Look for breathing rate, distress, that sort of thing.
Sure, visual checks.
But for critical patients, you need more. ECG is straightforward. Leads on the patient connect through those electrical pass-throughs to an outside monitor.
Okay.
Invasive blood pressure is common. Arterial line connected via pass-through to a transducer outside. You need a pressurized flush system to keep the line open and accurate. And properly zeroing that transducer before the dive, checking the waveform super important, especially with patients on vasoactive drugs where BP can change fast.
What about non-invasive BP?
Options exist, like automated cuffs or Doppler, but some older systems aren't available anymore. It's often supplementary to the arterial line if one's in place.
And for ventilated patients, what specific breathing parameters are watched?
Key things are respiratory rate, the actual volume they exhale, PP level, airway pressures, the O2 supply pressure to the ventilator, and if they're taking any breaths on their own. End-tidal CO2, its CO2 monitoring is really valuable too. You sample their exhaled gas via a pass-through. You just need to remember to apply a correction factor to the reading because of the chamber pressure. You can use it for intubated and sometimes even non-intubated patients.
And blood gases, you can draw blood inside.
Yes, arterial blood gases, or ABGs. There's a specialized setup to draw blood safely from the arterial line through a pass-through. Minimizes risk of air getting in. The text mentions older and newer blood gas analyzers, noting potential accuracy issues at very, very high oxygen levels with some newer machines.
Drawing blood under pressure sounds like it has its own risks.
It absolutely does. Air embolism is the big scary one if technique isn't perfect. Rapid blood loss if a connection fails. Clots forming in the line. And you lose a bit of blood just clearing the line, the dead space volume, before you get the real sample. Some places might even reinfuse that small amount of blood.
And what about patients with bad lungs to begin with? Do they get the same oxygen boost?
That's a critical point. Patients with underlying lung problems might not reach those super high arterial oxygen levels, even at standard hyperbaric pressures.
So you might need higher pressures for them.
You might consider it, but the evidence isn't really strong that it improves outcomes. Plus, some ventilators, like that Seachrist 500A, struggle above 2.0 ATA, especially with sick lungs. Honestly, the ideal PO2 level is still debated. Measuring tissue oxygen directly would be best, but we can't really do that routinely yet.
So, general guideline.
Generally, you try to avoid HbO2 if a patient needs more than, say, 50% oxygen just at normal pressure, unless the benefit seems huge. And if you do treat them, you absolutely need frequent ABG monitoring.
Any other monitoring possibilities?
Yeah, the text mentions you can monitor intracranial pressure, ICP, and even brain waves, EG, through pass-throughs. And transcutaneous oxygen monitors measuring O2 through the skin can sometimes help predict wound healing response.
So much monitoring. How is the patient actually managed during the treatment?
Again, it comes back to that experienced critical care team. Constant training, maybe ICU rotations for the hyperbaric staff. Having physicians boarded in both critical care and hyperbaric medicine available is key. If the patient isn't alert, intubation for airway protection is often the safest bet. If they're agitated or combative, sedation is usually needed, often complex regimens like fentanyl and propofol infusions. That also means you need arterial BP monitoring and pressors like levofed running through a central line.
And if you need to use paralytics?
Absolutely crucial. They must be adequately sedated first. Paralytics don't sedate. And then you have to monitor ventilation, even more closely exhaled volumes, pressures, looking for auto-PEEP because they can't show you signs of breathing problems or oxygen toxicity like seizures.
Right.
But those air breaks become even more important then to reduce the CNS oxygen toxicity risk. And the staff managing all this sedation, paralysis, they need serious credentials. It's basically like providing general IV anesthesia in a very unique setting.
Okay, let's talk IVs inside the chamber. How does that work logistically?
Meds and fluids go through those sterile IV pass-throughs in the chamber wall. They connect the pump outside to the patient inside. Flushing the lines properly is key.
Are there special IV pumps for this?
That's a tricky part. There aren't really any pumps specifically FDA approved for inside a Monoplace chamber, but some standard pumps, like the Baxter FlowGuard 6201, often tweaked by hospital engineers, or the Zyno 800F, can work up to certain pressures. Bioengineering departments are crucial here.
I see.
You also need one-way valves in the tubing to prevent blood backing up if there's a disconnect outside, and use Luer lock, pressure-rated tubing inside.
How do you give a quick IV push medicine?
Usually via a three-way stopcock, right at the pass-through, close to the patient. But you must give a big enough flush afterwards to clear the drug from the tubing's dead space and get it into the patient. The amount depends on the tubing. The text gives examples.
And you have to be careful starting potent drugs like levofed.
Very careful. Don't want to accidentally give a huge bolus. Things like TPN or insulin drips usually just continue running. Even tube feeds can run through a dedicated pass-through, just need secure connections.
And constantly watching how the patient responds.
Absolutely. Sedatives can affect breathing, pain meds can drop blood pressure, detailed flow sheets and documentation are vital.
You mentioned older chambers might have limited IV ports.
Yeah, a real challenge. Multi-line pass-throughs were developed as a workaround, following ASME PVHO safety rules for modifying the chamber hatch. Newer chambers usually have more ports built in.
And what about septic patients on pressors getting hypotensive during pressure changes?
That can happen. It might be because the pump delivers the pressor slightly less effectively under pressure, so you might need to give extra fluid or adjust the pressor dose proactively.
All right, final big topic, ventilation inside the chamber. When is it needed and what's unique?
You need for things like severe gas gangrene, necrotizing fasciitis, bad CO poisoning, or arterial gas embolism affecting breathing.
Okay.
A key thing is using a large enough endotracheal tube. Gas is denser under pressure, increasing resistance, making it harder to exhale, especially with stiff lungs or high PEEP.
And if there's any doubt about their airway or they need heavy sedation,
Then intubate beforehand. Safer. Prevents aspiration, prevents CO2 buildup if they get too sedated.
what ventilators are actually used in the U.S. for monoplace chambers?
The Seacrest 500A is the historical workhorse.
Yeah.
Pneumatic, time-cycled, controls outside. You set flow, inspiratory time, expiratory time. Tidal volume comes from flow and inspiratory time. Rate from expiratory time. Oxygen comes in through a pass-through. PEEP is added with external valves.
But it has limitations.
Oh yeah. It's control mode only, so often needs sedation or paralysis. Performance gets iffy with high ventilation needs, or above 2 ATA. Needs good driving pressure. Volume delivered can change during pressure changes, and it lacks sophisticated alarms. Requires really close watching.
You mentioned inverted IE ratios and auto-PEEP.
Yes, to get higher ventilation, you often end up with longer inspiration than expiration, which risks trapping air auto-PEEP. Tidal volumes might be kept small, maybe allowing CO2 to rise a bit, permissive hypercapnia. It takes real expertise to run it well.
Are there other ventilators?
Others like the Omnivent, Max O2, Magellan are similar. Omnivent might perform a bit better at pressure, but still needs experience. The Atlantis ventilator is FDA approved for monoplace use, but
Yeah.
the author had limited experience with it.
Any electronic ICU-like ventilator?
There's the Serotron 1000 IPUR. It's electronic, has more features,
Yeah.
but no FDA approval for monoplace use in the U.S. Plus, it needs the chamber filled with air, not oxygen, and an overboard exhaust for fire safety. And not much published data on its performance in this setting.
Wow. Okay, it is incredibly clear. Treating critically ill patients in these chambers is, well, it's a whole different world of medicine, so specialized, so demanding.
Absolutely. It's possible, it's safe when done right, but it takes that obsessive attention to detail, the specialized gear, the modified equipment, and crucially, that highly skilled integrated team. It's critical care extended into a very unique box. The adaptations for monitoring, ventilation, IVs, it's really quite amazing.
So thinking about all this adaptation, all this ingenuity to make standard medical practices work in such an extreme environment, it makes you wonder, doesn't it? How could these principles apply elsewhere? Maybe space medicine or delivering critical care in really remote places?
Those are great questions. The lessons learned here definitely have potential implications beyond just hyperbarics.
Yeah.
For those listening who want to dive even deeper, the chapters we discussed from Hyperbaric Medicine Practice are a fantastic resource. And organizations like the Undersea and Hyperbaric Medical Society, the UHMS, are great places to look for more information and research.